Hello, everybody, and thank you very much for joining in this very exciting session titled A Practical Approach to Shared Decision-Making When Treating Heart Valve Disease. This, I promise you, is going to be a very exciting, unique session, primarily with one objective: keeping the patient at the center of our conversation as it relates to heart valve disease. At the end of this hour, our objectives are to provide some level of clarity on the evolving heart team model, essentially develop some actionable plan or give you actionable insights and resources that would help reinforce shared decision-making concepts, and more importantly, share examples of how these practices can impact and are impacting patient satisfaction as we speak, and where we need to go from here. So thank you very much for joining. It is my distinct privilege to present before you this very diverse list of esteemed panelists who bring essentially a broad spectrum of clinical voices within cardiology. First and foremost is Dr. Howard Herman, who is the Director of Cardiac Catheterization Laboratory and the Health System Director for Interventional Cardiology at University of Pennsylvania. He clearly does not need any introduction in the field of structural valvular disease. Next is my esteemed colleague and good friend, Dr. Purvi Parwani, who is the Director of Cardiovascular Health Clinic, Women's Cardiovascular Health Clinic at the International Heart Institute in Loma Linda University in California. Next is Kristen Pasquarello, who is a physician assistant and advanced practice provider who would serve as a very crucial link between physicians and patients. She's the administrative director of St. Francis Hospital Heart Valve Center. And last but definitely not the least is Adam Pick, who is a patient advocate. He's an author. He's a patient, author, and founder, basically, of heartvalvesurgery.com. And myself, I'm Milind Desai. I am a cardiologist at the Cleveland Clinic in Cleveland, Ohio. So it is basically, you will hear in the next hour how the team approach is conceptualized and how it works in the big picture. So what is the heart team? Basically, heart team, it's sort of, I think of heart team as a football team or a basketball team or what have you. Everybody, each player contributes to the success of the team, and in this case, the clinical success of the patient. Remember, the patient is at the center of it all. And today, in 2021 and beyond, we are all part of the heart team. No longer are the days when the doctor walks into a patient's room and say, this is what you need, this is what you're gonna get, and he or she walks out. Today is the referring cardiologist, the imagers, the structural cardiologists, cardiac surgeons, and most importantly, the patient and the patient advocate groups also play a very important role. What is the primary goal of all this is to ensure that the patient is empowered at every phase of their care journey, from not only at the level of diagnosis, but through treatment and long-term post-care treatment. So without further ado, I think we should get going. You are gonna see one after the other. We will have Dr. Purvi Parwani start off, followed by Dr. Herman, and followed by Ms. Pasquarello. So it is my distinct pleasure to introduce Dr. Parwani, who will discuss the role of a general cardiologist in the patient care pathway. Purvi.
Thank you, Dr. Desai. Really honored to be here, and thank you for your kind introduction. So I think that when I think about the heart team, I think valvular heart disease is that best paradigm, perfect paradigm for heart team application, right? And I think, as you correctly said, the main beneficiary of this approach is our patients. They are in the center of this all. So I think when I think, I'm a general cardiologist, I'm also a multimodality imager. So at our institute, we have this very a nicely established workflow, which is established, I think, in most of the academic centers in United States. But a referring provider, sends the patient to valve clinic, where the patient meets both the interventional cardiologist as well as the surgeon. And then there is this approach of, getting the diagnostic imaging, bringing the imager, in the question, then, having the valve conference, getting the procedure done, getting that care in the hospital taken care of, and then sending the patient back to the referring provider. And I think on the right side, you see that I've included some pearls. So I think as a general cardiologist, effective communication is so important at both the levels, like how you speak to your patients, but also how you speak to the members of the heart team, right? And what you establish. And I think providing that complete information to the team that is going to take care of your patients, as well as providing the information to the patient of what they deserve to know, and kind of prepping them for that first visit in the valve clinic, and doing it in a very respectful and culturally sensitive behavior, and being very aware of needs that patient may have as they go through the treatment, is very necessary. So with that, I think Dr. Herman has the next slide.
Thank you very much, Purvi and Milind, and welcome to Adam and Karen. So I think that's a very nice description, Purvi, of the way the heart team should work and how we would take care of patients. But I think it's also important to recognize some of the practicalities of what we do, and that it's sometimes difficult to have that ideal interaction the way we would like to have it. The heart team has become recommended as a class 1 indication now for patients with severe valvular heart disease, that they should be evaluated by a multidisciplinary heart valve team when intervention is considered. But the realities of day-to-day practice can sometimes make that difficult. And so I thought I would share with you some of the ways that we do this at the University of Pennsylvania. We're a very large academic program. We do over 1,000 valve interventions annually, and we do them at 2 very close, few blocks away geographically, close and intertwined hospitals. And so we have sort of several ways that we try to come up with that ideal valve heart team meeting. We do have weekly heart team meetings, although they're done separately at each of the hospitals. And so that's a good place to bring together all of the people involved, the surgeons, the interventionalists, the imaging experts, even our anesthesiologists. But we can't present that many patients in a limited time frame at every weekly heart team. So sometimes we do it in a shared clinic environment, which I think is a particularly good way to do it, when we can have a patient evaluated at the same day or sequentially, or even at the same time. For TAVR, for instance, an interventional cardiologist and a surgeon. Sometimes we see the patients simultaneously, sometimes we see them right after each other. But we also sometimes, just from the practical standpoint, have to do this sequentially. A patient who's not referred through the valve clinic, but just shows up in my office for an evaluation, I may not have a surgeon available that day to evaluate the patient. I may not have all the imaging available. So sometimes that patient either has to come back to see a surgeon in a sequential fashion, or sometimes we even converse by email when it's an obvious patient who is not appropriate, for instance, for surgery. So what's supposed to happen and what happens is not always the same thing in these somewhat inefficient interactions. We want to have knowledge transfer and technical considerations discussed. We want to, of course, consider the patient preferences. And then we hope to have deliberation that leads to a consensus for treatment between both the surgeons, the interventionalists, and the patient. Next, please. So what can we do better? Well, I think we have to recognize that one size may not fit all in every situation. More time may be required for a complex decision where there's more clinical equipoise and more uncertainty than in a, say, very elderly 90-year-old patient who's not considered for surgery, but might have the appropriate anatomy for a MitraClip repair of their mitral valve regurgitation. Decision aids can be helpful for the patient, though despite improved patient satisfaction, these have not been perceived as particularly beneficial by clinicians. Next, please. In summary, I think there are barriers for the successful implementation of shared decision-making by the heart teams. And I think what we're presenting to you today are some of the ideal ways that this should be done, but as well some of the practical issues that make it less than ideal in some situations. And I think it's going to be important for physicians to support patient engagement in this process. Next slide, please. So we're moving to Karen Pasquarelli, who's going to talk, I think, about the role of the very important role of the valve program coordinator in the heart team.
Thanks, Dr. Herman. So everyone always, questions what is a valve program coordinator? And at each institution, I find that this role of the valve program coordinator is either occupied by a different type of person. Some programs have nurses, other programs have advanced practice providers, other programs call them nurse navigators, some programs call them the director of the valve center, as with myself. But basically, we all have the same job. And our job is to really act as that point person for everyone throughout this process. So all the people that we're talking about, the referring physician, the patient, the interventional cardiologist, the cardiothoracic surgeon, we have to coordinate everyone all together and make sure everyone is on the same page. I also schedule and I plan the agenda for these weekly meetings that Dr. Herman spoke about at his institution. And I ensure that everyone who is supposed to be at these meetings are appropriately invited and have the correct information to properly plan for the patients. Most importantly for this conversation, I'm the first person that introduces the program to the patient. I set the tone from the initial call. I make sure that everyone who needs to be at the appointment, support-wise for the patient, is there. I educate them about the process, meaning this is not going to be like any other appointment you've ever gone to. There are a lot of people involved, a lot of records need to be found, a lot of testing, and to ensure that we help guide you to make the best decision for your treatment plan. I also conduct thorough assessments, so I'm a clinical PA, and other institutions, like I said, have other APPs involved. So I am introduced with the physicians during their appointment, so the patients feel comfortable going to me as that point person in between the physicians and their referring and kind of connecting the dots for them. Next slide. So keeping the patient at the center of everyone is obviously what our goal is, but I feel like the coordinator is kind of the dotted line between each of these people, because we really communicate throughout the entire process, and we ensure that everyone is on the same page, including the patient. So a lot of questions come to us, a lot of patient questions. They kind of get starstruck when the docs come in. They don't know what to ask, and then after they'll call us to kind of go over everything. And we're more readily available than the physicians who are in and out of the operating room and the cath lab and running their busy practices.
Thank you so much, Kristen. So we will reserve the questions for towards the end, but please, the audience participation, I think it would be good to have some questions. So moving on to this next set of discussions, excellent discussions coming up on equally important topic, which is the shared decision-making in practice. Now we have a lot of choices, and patients are and have to be empowered about where they need to go with regards to their medical care. So without further ado, we will talk about shared decision-making and why is it critical. Purvi will take on from here for a few slides.
Thank you, Dr. Desai. So I think shared decision-making is evidence-based decision-making, right? And shared decision-making has shown not only to improve the outcomes, but it also has shown to improve the patient satisfaction. It has decreased the decisional conflicts, and overall, just better outcomes, both for patients as well as for the providers. So I think, I see this in like three major components. So the shared decision making has three major components. Number one is you need to identify the problem. Once you identify the problem to the patient, that this is the medical problem, this is the valvular problem that you have, then tell them that there are more than one choices that exist. And then make sure that you put emphasis that you have respect for what they have to bring in this decision making. The second thing is presenting the information about all the reasonable options. So these are the reasonable options that exist, and check with them what misconception they may have, or what knowledge they have, and identify what misconception within that knowledge they may have, and correct them before you present those options to them. And then the third thing is the real decision talk. And I think here we should probably keep ourselves open-minded and defer, rather just put the focus fully on the patient preference than putting the focus on making the decision right at that time, because sometimes patients require more time, and I think that we ought to be open about it. So I think that's how I see this process of shared decision making. Sometimes I feel like basic patient education gets confused with shared decision making, and that's why I thought that it would be important to break it and kind of identify all different parts. That can be done in a very quick manner if we keep ourselves organized during a busy clinical practice. I think I have one more slide after this. Next slide. Yeah, so I think this was a ACC survey of 150 cardiologists, and they also did a parallel survey of more than 3,400 patients and caregivers, and they showed that we all have one common goal. Both the groups wanted the patient and the doctor dialogue to be improved when it came to discussion of best treatment pathways for heart valve disease. So in this survey, the cardiologist survey, 75% of the cardiologists said that they discuss treatment options with patients at the time of diagnosis, and 90% of the patients reported that doctor-patient dialogue was the most important and influential factor in determining their treatment decisions. So that just goes to tell you how much our patients trust us and how much is it, we ought to give them the information in more comprehensive manner. Thank you.
So picking up on that, I think I was asked to talk a little bit about the implanter's perspective in this as a interventionalist. And I just want to highlight two things I've already heard. One from Purvi, who was talking about how we have to listen to our patients. It's not enough for us to have our viewpoint on what we think is best for the patient. We have to understand from the patient's viewpoint what they want. And then from Kristen, I think one of the key things she said that I picked up on that I think we should emphasize also is the fact that patients don't always know to ask us, particularly the physicians, when we walk in the room, the right questions, and they think about it later. And then they're much more likely to call back to the advanced care provider or the valve coordinator, whoever they also met, to ask those questions and to make their preferences more clear. I think as an implanter, we often focus too much on the procedural success and mortality of the procedure rather than the patient's preferences. And that may be influenced either in a good or bad way by some of the public reporting that is coming out now. But I think surveys suggest that patients are much more interested in the complications and returning to an active lifestyle, and we need to balance those differences in perspective. Some of the survey responses that go to these questions are that we found that in that survey, 70% of cardiologists said risk mortality is the most important factor when determining the best treatment option for patients. But 49% of patients cited a return to an active lifestyle as the key factor in their treatment decision, and those don't always match. And only 34% of cardiologists state the ability for their patients to meet or return to the goals they have chosen for themselves, such as active living, among the major factors in determining the best treatment options for their patients. Next slide, please. So as an example, chose this one, the considerations for transcatheter mitral valve intervention. So this is a population of patients with severe mitral regurgitation that are often referred to me because we're involved in both repair and replacement from a transcatheter standpoint. And some of these patients come to us from surgeons who have already deemed them to be high risk or inoperable, for example. And so we're having a discussion with the patients about what I think should be safety and effectiveness and the relative safety and effectiveness. We don't want to recommend procedures that fall into that upper left box of being very invasive and not safe and also not very effective. We want to have treatments that are in that lower right box, less invasive, faster recovery, and similar efficacy to surgery. But right now, our procedures aren't in that box for the majority of patients. For instance, for TEER or transcatheter edge-to-edge repair, very safe procedure with fast recovery, but maybe not always perfect efficacy. And then we have transcatheter mitral valve replacement, sits up in that upper right box, where still very effective, but maybe not quite as safe as the MitraClip procedure. And I think both of these procedures need to move closer to that right box. And the things I have to discuss with my patients and think about when I'm making this complex decision on an individual basis are to take into account the patient age. The goals of care for a 70-year-old may be very different than the goals of care for a 90-year-old. Maybe a safer but less efficacious procedure is appropriate for that 90-year-old that may not be so for the 70-year-old. We need to consider frailty, comorbidities, the patient's goals of care. And then in addition, for each procedure, the specific valve anatomy that makes a procedure better or not better in that patient, safer or not safer, and the specific safety and efficacy of each device. So I think these are very complex decisions that require understanding not only of the patient preferences and our tolerance for what we want to do, but each device and for each patient may vary in terms of how we put those relative considerations together to reach the best decision.
So thank you, Howard and Purvi and Kristen. This was excellent. So basically, physicians believe patients, all of us agree that patients could be better prepared for conversations concerning treatment options. But I find this interesting that more than a third of patients wish they had asked more questions at the doctor's appointment during the visit. And while on the flip side, the cardiologists feel that patients are not as informed as they should have been about their treatment options. So there's this dichotomy, and I think we as a medical community can and should strive to come to a happy medium. Kristen, how do you help understand, your patients, what questions to ask? I mean, is there a role for a prep meeting before the actual Super Bowl when they come to see the heart team? I mean, how do you best help them? Can you help navigate that?
Yeah, that's actually a great scenario you just kind of painted in our heads. We kind of do a prep meeting before the big event, the big valve center meeting, and what that entails is a phone call from one of the APPs on the phone to kind of go over exactly what's going to happen so that they could expect, the layout of the day, the Super Bowl as you mentioned. So we tell them that this is the day you're going to meet the team. And this includes the interventional cardiologist and the surgeon. So we're going to talk about all the treatment options that are possible, whether it's surgery, whether it's TAVR, whether it's TMVR, whether it's MitraClip, whatever it is, the doctors that you're going to be meeting that day are going to tell you what you qualify for. And it could be more than one thing. It could be just one thing, but you're going to hear all your options. We actually prep them by sending home a folder that has a lot of information regarding transcatheter therapy, regarding surgery, regarding, any treatment option that would be possible, specific to whichever type of valve disease they're coming in for their evaluation for. And we tell them to read it. Patients do, they listen, they come in with it highlighted and underlined, and what does this mean and what does that mean? But that's a good thing. That means they're prepping, for their appointment, and they're preparing themselves. So I love that when they come in with a list of questions with our little pamphlet all marked up. And I also tell them, make sure they come in with whoever their support system is, whether it's their family or we can get them on the phone. Of course, now we've adapted with COVID to a lot of virtual meetings with them while they're in the room. But this is their time for whoever their support system is to also come and ask their questions and hear about the process as well. We also include the referring physician because they know their patient the best. We're meeting them for their first time. So we've called them directly in the room. If it's not a clear-cut case, what do you think? We always follow up, of course, after to let them know what we think, but we really want to include everyone so that the patient feels comfortable in making their informed decision. So a lot of prep work, I think, which is key.
And also laying up expectations on the day of the visit that they may not, everybody's part of a team. This is, so they may not get to, just because they don't get to talk to Dr. Herman on day 2, 3, 4, 5, 7, 8, 9, 10 is okay because there may be somebody else in the team who can answer the question. So anyway, that was excellent. So from my perspective, the top 3 teams, 3 items that cardiologists believe would better prepare the patients would certainly include having a family member or a friend attend the visit to take notes and ask follow-up questions. Of course, we know during the COVID times, this has become a bit challenging, but folks have adapted nicely. 59% seem to think that's important. 53% seem to think that use of a decision aid is important, and cannot underscore the importance. Come with a list of questions to ask during the appointment, because that I think is when everybody is zoned in and have undivided attention. So with that, I would like to introduce Adam Pick from who would represent the patients. Adam, do you agree with this data, or would you have your own perspective?
Yeah, so thanks so much, Dr. Desai. And before I go ahead and answer your very important question, I just really want to acknowledge the ACC and Medtronic for actually all the great work that you guys are doing, bringing together all of these resources to have this very important discussion. So as a patient, as I answer these questions, I want to let you know that I'm bringing in my perspective, but I'm also bringing in about 14 years of patient advocacy work that includes qualitative analysis and quantitative metrics, which you'll see to help really give a well-rounded response to, again, these survey responses. So the first one, family members being present at appointments. Let me tell you about my personal story. My mom was with me at my cardiologist. My dad was with me at my surgeon consults. And I even brought along my brother to my cardiac rehab appointments. And why is that? Because it just helps the patient process, interpret information, digest information, share information, and discuss. So full support of that. Use of a patient decision aid. This one kind of falls outside of my realm of knowledge. I don't know much about what those decision aids are, but as a technologist, anything that can algorithmically provide some results or validation for thought processes, I'm all for. But then again, technology, who's using it and how they're using it. We all know that every time you get a new iPhone or some technology, there is some learning that has to go there and some behaviors that need to adjust. Bring question list to appointment. No doubt, white coat anxiety is rampant. And it is probably heightened when you're talking about something that is as near and dear to all of our hearts. So I not only encourage patients to bring questions, I actually encourage them to record the session on their smartphone because, as we all know, you can only remember so much information. And when you're hearing health terms, it's not always easy to really understand what's being said that first time, but if you listen to it on playback, that definitely helps. If you're wondering, my story is I was born with a bicuspid aortic valve. I was asked to talk a little bit about it to see what my heart team did well. And I had aortic stenosis and aortic regurgitation. I was real active when I heard that I needed to have heart surgery. I'm a runner, I'm a swimmer, I'm a surfer, I'm a skier. And so I wanted, just like you saw in that survey that was already addressed, an active lifestyle. And maybe naive at the time, but I'm 33 years old and I'm thinking to myself, I want a one and done, right? And that's, I think, what a lot of people think here. This is going to be a one and done, show me the perfect valve, which we know, again, doesn't always exist. And my medical team did a lot of great things. They offered options. They listened to me. They shared the risks of one procedure versus the other. And they explained, because I was so young, what the re-op scenarios could be for me as a congenital patient. Interestingly, consensus for me, and I think this was just a fantastic gift, came quickly. So I met with two surgeons. They both said, hey, the Ross procedure is something that could be of value to you. Luckily, knock on wood, I'm approaching my 16th anniversary and I am completely free from any reoperation. Again, knock on wood. So my story is one, though, that is archived, right? Because it was all the way back in 2005. That is not what patients today are experiencing. They're experiencing what I consider to be a much different setting for valvular treatment option decision-making. And the baby movers are in full effect, right? This cohort of 70+ million people are doing what they've done, whether it's Lee Iacocca's minivan or Jane Fonda's workout tapes, they are consuming and they are very, very good at it. And so as they shop, the therapies that are available to them are, I think we all agree, much more today than they were 15 years ago. SAVR, TAVR, TMVR, big R, little r, minimally invasive, robotic. You might hear Ozaki, heart annuloplasty ring, valve and valve, all these things. Then the taper of that is the recovery. So cryoanalgesia, rigid sternal fixation, all these things could be complicating the process for patients today. And you're also hearing, as people live longer, what's my lifelong plan, right? We just did a video with Dr. Wilson Zito all about this. What do I need to think of today going forward and even forward after that next potential second intervention? So at the end of the day, I'm going to echo what I've heard several times here, which is just, it's about the patient. Said different, patient centricity, I think, always helps. If you can listen to their individual needs, which are stated, you might actually hear some of the latent needs that they don't even really know how to contextualize for you. So I hope that helps with some key considerations. Going on to the next slide, what you're going to see, this is fresh. I don't know if it's called hot off the press, hot off the survey press, but just a few weeks ago, we did a survey of, it was a 4-day survey online. We surveyed 2,000 patients. And I pulled this out for the conversation today. I thought it was interesting. Is one of the questions is, what is most important for you when talking to a doctor about your heart valve treatment? And you can see, listening to my concerns, spending as much time as needed to explain my options, answering my questions. But the number one thing was, include me in the treatment selection process. I think that really speaks to what we're talking about here today, is patients want to be part of your heart team. Next slide. The challenge with that, though, and again, this has also come up, is the education. And Kristen, I love hearing about all the materials you give your patients, but for post-operative patients, when you ask them a true false question of, my medical team provided me the educational resources I needed before surgery, there's kind of like a happy face, sad face scenario here. Happy face is 57% of patients said true. But look over on the right side, 42%, almost 43% of patients said false. There's still much more education, I believe, that needs to occur. And if it occurs, then what happened? It empowers the patient to be part of what? Your heart team. Hope that helps.
So thank you, Adam. That was terrific, and always absolutely crucial to understand the perspective of the patient. And you are basically, you are their biggest cheerleader, and you have street credibility. You underwent sternotomy when most people would not at the age of 33. So to summarize over what has been an engaging last more than a half hour, is the heart team model has evolved, is evolving, and all heart team members and diagnosing cardiologists play a critical role in a patient's journey, in fact, I still think the last word has not been written in this, and it is evolving. More and more patients and family members are becoming a part of the conversation. Guidelines. Well, guidelines are guidelines. They guide us. They tell us what we should do. But the application of guidelines, it does require coordination across multiple healthcare stakeholders. It's sort of like you may have 100 million vaccines, but what matters is vaccinations. So the same concept here. Individualized patient care is the foundation for optimal shared decision-making. One size does not fit all, as Dr. Herman has said, as Adam has said, demonstrated. There are a buffet of choices for the same valve. And active use of decision aids, hey, we are 2021 and beyond, artificial intelligence, machine learning, apps, everything is coming along very rapidly. So active use of decision aids, 3D models, questionnaire, and do not underestimate the power of questionnaires. The kind of survey that Adam shows, we may think, I may walk out of the patient's room thinking I have done a great job of explaining, but 42% of patients still walk out confused as ever. Then we need to do a better job. We need to identify how we are going to do this better, and continue to educate the patients and empower them so that they are well invested in their healthcare journey. I think so that is overall the gist of the HEART team as well as shared decision making. I had a blast with this session, and I think in the grand scheme of things, we should be having a Q&A session and a broader conversation. So any questions in the chat box? So question 1 from the audience for Dr. Parwani. General cardiologists are on the front lines detecting the early signs and symptoms of disease and managing timely referrals. How have you established effective relationships with implanting physicians? Purvi.
Yeah, that's great. I'm at the academic center, so it's a bit easy for me, but I think in general, I'm a multimodality imager. So, I think in general, what I see, what are the biggest challenges speaking to, our team is that, as a referring provider, if you want to establish that relationship with the HEART team or with the, implanter, I think you ought to give them complete information. So, often we get patients from outside where it's literally just any valvular diagnosis and patient ends up in a valve clinic, which is okay. But I think that giving the implanter the right information, what exactly is the severity of the valvular lesion? Why do you think, if it is severe, why do you think it is? Is there any cardiac catheterization that's being done, or are you asking, the implanter to do it? So I think kind of, making sure that all those things are checked, before. And I think communication, I come back to this. I think that we ought to have that collaborative, spirit when we speak to our colleagues, and we need to communicate often about what exactly is happening to our patients, what are expectations from the implanter, and then what are expectations after these issues are taken care of, right? So when the patient comes back, you need to know what happened, with this patient. And if there were any complications, you need to be debriefed, and you need to have that communication going with the implanter. So I think that those are the things that I consider as a general cardiologist that, are very important and, really crucial in establishing that relationship.
So thank you. That was awesome, Purvi. Howard, I have a question for you pertaining to what this exact question is. Referral to a valve clinic, it's sort of like a circle. I mean, it's like a wheel and where the hamster enters into the wheel, it matters. So in your place, say you get directly referral from a general internist in the community. Do you routinely involve a broader perspective, like not just an image? Would you call a Dr. Parwani not just to read the echo, do the TE, or read the CAT scan, but also consider, hey, this person may have concomitant amyloidosis, or this person may have some other geriatric issue. So how do you work in your organization?
You know, it's a great question, Melinda, and I think each patient's a little more, is more individualized than that. And it varies both what workup's been done, who sent them in, and what I think needs to still be done. So for instance, in our clinic, I do have referrals like that. I have patients who are referred to me by general cardiologists who just want my opinion. This patient has aortic stenosis. It's not quite severe. They have some symptoms. Maybe it's their COPD. Where do we go from here? Do you think they need a TAVR? That kind of question comes up regularly. And so I have to evaluate that patient, look at their echo. Sometimes I'll pull in one of my imaging colleagues to look at the echo with me, or I'll walk down to the echo lab and review the echo with an imager to get a sense of whether I think it's severe or not. They may not have been scheduled for a multidisciplinary visit with a surgeon with me at the same day, and they don't want to come back. So then I sometimes have to scramble a little bit. There are surgeons seeing patients in nearby clinics, but maybe not, this patient wasn't scheduled as a joint visit. And so those are the practicalities of day-to-day working in a busy hospital, and it isn't easy. And I think we try to come up with a model for every patient. The patient who just calls the valve coordinator from scratch and says, I have aortic stenosis and I'd like to be evaluated for treatment at your institution, is a little easier to schedule all of those things ahead of time. But too many of our patients don't come in through that model. And so we have to scramble a little bit to try to get that heart team approach without having them come back for several more visits, one for the echo, one to see the surgeon, and then have the heart team approach. So I think it's still evolving.
Go ahead, sorry.
Go ahead, Purvi.
No, I was just gonna say, this just reminded me of something, one of our surgeons said months ago to me that, I think before this whole heart team concept had come in guidelines, right? Like way before, I think I'm early career, but they say that since these concepts have come into practice, there is a lot of collaboration that goes on. And I think that, there is a flow that is established between the team. The surgeon knows when to go to echocardiographer, or the, interventional cardiologist knows, who to find, because there is this structure that is established. And I think that really, I thought that was really pleasant to hear.
I think that's a really good point. I can think of one of our busiest heart valve repair surgeons sees patients on a day that neither of the two basic MitraClip operators at my institution are seeing patients. And so it's very common for him to give me a call at the end of a clinic and say, I saw, so-and-so today, 87 years old, has, P2 prolapse. I can operate on him, but he's a little frail. I'm wondering about whether he should have a MitraClip. He came with a transthoracic echo from outside. So I scheduled him for a TEE and follow up with you. And that would be the kind of scenario where we would do a heart team in sequence rather than a heart team on the same day.
Yep.
Yeah, that's excellent. Another question, this is for the panel, and I mean, cardiologists are busy, and we are all getting busier, and expectations are just ever increasing. So what can centers that are smaller, but also there's 500-600 TAVR centers. Not everybody is at a UPenn, Loma Linda, Cleveland Clinic level of volume. But what can centers with limited resources and a small clinical team do to embed shared decision-making concepts in day-to-day practice? I'd start with Kristen, your perspective. How can we make the best of the situation in a smaller center? And then like to hear other thoughts.
Yeah, I mean, I think even in a smaller center, they have a connection or collaboration with a larger center, for referral basis, right? So it's still that inclusion of that team with now the larger center team. If that small team thinks the patient, needs surgery, needs TAVR, needs whatever they need, they're going to refer to the larger center. So it's just inclusion of the referral base. Resource-wise, I think most places can get our basic echo and then take it from there and refer onward.
Okay, Anybody else wants to chime in? Howard, Purvi, Adam?
So I wanted to ask Adam a question. Maybe it's a little bit not quite on this topic, but you raised the issue of sort of lifelong treatment. And, I think we're struggling today talking about the short-term treatment and how to make shared decision-making. Yet I find that as important as that is, patients are not yet thinking that way. And I think we have to get that conversation started a little more often. I mean, it's easy when a 33-year-old with a bicuspid valve comes in to think about long treatment options, but less so at 65 and 75 years of age. And I have a lot of patients who just say, oh, I don't want to worry about it. I won't be alive in 10 years. Just tell me what I need to do now. But that isn't really the case. So Adam, I think it'd be worth talking about that a little bit. And how do we bring that into this shared decision-making?
Yeah, so it's a great question, Dr. Herman. And like all things, it's an evolution, and it's a conversation that we've been looking to stimulate in our community for some time now, and really accelerated that focus over the last, I'd say, 12 months. And the reason why is our community has been around for about 14 years. So what do you think we're starting to hear more and more and more now?
Yeah.
Valve is feeling,
yeah,
right? And so initially everything was what from the patients 10 years ago, 12, like you said, what do I need to do to live, right? Now it's shifted to what do I need to, and I'll give you a great example. I got a call the other day from a patient. I think he was, if I remember right, he was about 59 years old. And he said, how do I get to 90? Right? I've never heard that question before. And so I don't have a specific answer. I wish I did, a silver bullet, but what we're trying to do is sprinkle in throughout our content and our educational materials that we syndicate around various platforms, just getting the consciousness there that this might be coming down the road, because if you're lucky to get 10 to 15 years with your tissue valve, we've also seen, as you know, re-ops much earlier than that. So I don't know if that helps your answer, but I think it's kind of tying back to what we talked about earlier. It's the education and the coaching and the counseling. And one thing we try to do on our platform is stimulate that through multiple strategic feedback loops in things like an email newsletter, believe it or not, that is providing episodic content throughout the patient's life. So it doesn't just end when they leave, when they feel like they're recovered. We have patients who've been with us 10, 12, 14 years, as I've talked about. Does that help a little bit?
Yeah. One thing I'm going to say, to echo what Adam has said, I find myself more and more having the following type of conversations now than when I started early, 10, 15 years ago. Now we are, a youngish person in their 40s or 50s, we want to put the largest size prosthesis right now so that, 10, 15 years from now, we can do, valve in valve. It's now the mindset is how many valve in valves can we do to a person who is 50 years old and who's completely adamant against a mechanical valve. So, then you are not only explaining to the patient, but also making sure the surgeon is also on the same page. If you need to do an aortoplasty to increase the size of the annulus. So there's multiple conversations, but like Adam said, setting expectations is absolutely crucial. Not only the fact that they understand the current procedure, but what is coming down the pike, so that they are not completely taken by surprise or shocked. So that's great. I want to switch gears a little bit, more topical, I suppose, of the times. Several medical societies, including ACC and AHA, have elevated their focus on healthcare inequalities and the cultural nuances of specific patient groups. How, in your opinion, if any, does a caregiver's level of cultural competency impact shared decision-making conversations with patients? Remember, I did not use the term physician's level, a caregiver. So I want to hear from all the three caregivers on the panel. So we'll start with Purvi.
Yeah, no, I can go first. Yeah, so I think it's such an important question. Like we are such a diverse country. There's so much immigration. There's so much race, ethnicity, right? There's so many factors, and what we know is that cultural factors actually play a very important role when it comes to establishing or continuing the doctor-patient relationship or patient-doctor relationship, and we saw in that survey that was like the number one factor how patients make the decision, right? So patient decision making is dependent on what relationship we have with our patients, which in turn is influenced heavily by the cultural factors. And in my opinion, I think shared decision making actually enables us in this culturally challenging environment, because there's so much diversity. So it enables us to have those culturally competent communication with our patients, because suddenly there is this model that brings the doctor and the patient together, and patient is in the focus, right? So patient preferences are in the focus. So you're discussing evidence base, but it's in light of what values a patient has, or what cultural beliefs the patient has. So I think actually shared decision making gives us that opportunity to be culturally competent.
Kristen, what do you think?
Yeah, I couldn't agree more. And being the one that has the most contact with the patient and the patient's family, really getting to know who they are, both culturally and everything about them. I'm the one who usually is the one communicating before the doctor goes in to meet them, about the patient. If there's anything about them personally, I kind of make that connection ahead. So I think having this shared decision making, having the patient in the middle, really does bring all of this together, and includes having a big group of people, right? Having this diverse group, it includes a lot more people. It's not just one-on-one. So I think this is definitely beneficial in that regard.
Avi, what do you think?
Sure, of course. I mean, I think it's both cultural, it's also financial healthcare inequities, but it's also just listening to your patients. It's not uncommon to have somebody come in and say the reason they want a TAVR is because they're the sole caregiver for their spouse who's ill, and they want a TAVR because their recovery will be faster. Whether or not it's the right thing from a medical standpoint, in my view, or the surgeon's view, may be irrelevant if that's the patient's perspective on what needs they need to have done. And that can be non-cultural, but it can also be cultural. There are families that live together in large groups. They may have the financial means not to be away from their family. They can't get another caregiver for a sick spouse or relative. So I think it comes down to listening to our patients very carefully.
Thank you. Adam, are you satisfied with the answers you got from the caregivers?
This has been such a great session. I am beyond satisfied. I love hearing all the great ideas and information you guys are sharing on behalf of the patients. So thanks so much. Yeah.
So there's a question for specifically Kristen. What challenges, if any, have you experienced when coordinating care between referring physicians?
Oh, no challenges. No, I'm just kidding. So I think we've come a long way through the years. I mean, our valve center is about 8 years old, and I think programs have really progressed. I think as education has gone out there and referring cardiologists learn more about our program, I think it's gotten easier. But I think challenge-wise, no referring physician wants to give you per se their patient, right? We have to make it really clear that you're referring your patient to us. We're going to take care of them. We're going to package them up, and they're going to refer back to you to continue on their care. So I think including them in the process and making it seamless for them is really has taken us a long way. And you have one good experience, they'll send you more patients. So I think that was a challenge in the beginning, that why am I going to refer, my patient to them, and thinking they're just going to kind of continue to follow up with us. So ensuring that this is a team approach. We want to take care of your patient, and then you'll continue to care for them, including them in that conversation of, your patient best, and their social and cultural and everything life. So a lot of communication has helped get past those challenges.
Thank you. Adam, your organization, we are coming close to the end of the hour, so, but this is an important question. Your organization has educated thousands and thousands of patients. How have you seen that evolution of patients' needs? And, as us, how should we, as us on the other side of the aisle, how should we plan, and what trends should we be aware of?
Wow, so I think this is one of those tough questions to answer, and to answer it, I think we need several hours, given all the analytics and data that we're processing over here in terms of how patients are managing heart valve disease. There's a couple I could throw at you. The first one is patients want to know all of their options, right? And what I mean by that, and this was surprising to us, we did a clinical trial survey of 1,100 patients last year. Only 4% of the patients that we surveyed had been in a clinical trial. But take a guess what percent of patients would consider it if they knew about a clinical trial. It wasn't 10%, it wasn't 30, it was 59% of patients. Okay, here's the unfortunate part. And it's the missed opportunity too, I think, is 73% of the patients were considered not very aware of clinical trials. And in fact, that 72% could not even name one clinical trial. So that's one thing. They want to know what is out there. The other thing is we're talking about the education, and Kristen, I love what you're doing with all your materials you're providing. Facebook is changing the game for digital health, right? And if you can harness it in the right way, it can really help not only your center, but it can help your patients. And real quickly, 7 years ago, we didn't have any followers. Today, we have over 345,000 followers. Why is that important? It's important because the ease with which patients can get educated when the incredible algorithms are looking at the interest profiles of the users as they're scrolling through, it's an opportunity, right, to help them throughout their entire journey to healthy heart valves. And the final thing, if I was to throw something at you, what we just have seen really diversify over the last few years are self-referral patterns, right? I think Howie, you talked about this earlier. It used to be that people on our platform only reached out based upon a name. They wanted to contact a surgeon. And now what we're seeing is patients who are saying, hey, I would like to have that device, or I would like to learn about that clinical trial. And the reason we know that is because we track the analytics on phone calls placed through our platform. And last year, even though it was COVID, we saw over 8,500 phone calls being placed to learn more about these different opportunities for treatment and people. So I tried to boil it down for you, Dr. Desai. I hope that I got a couple of things across for you.
No, that was awesome, actually. Any last words of wisdom, Howard, Purvi, Kristen, as to where you think the future is headed?
Nothing specific. I just want to say this was a great session, and thank you for including me in it.
Thank you so much. Yeah, I have to admit, Purvi, do you have any last words?
Oh, I was just gonna say, I think future is headed more and more, towards percutaneous options, because I think, that's what I think. But this was a great session. And I think that, shared decision making, those words sound like really big in our, like when we think about it, but it's really communication that involves patient. That's what it is at the heart of it. So thank you again for inviting me.
Kristen?
Same, thank you. And I think in my career, I never thought, when I was in PA school that I would be in this role. And I think it's a really unique opportunity for me as a mid-level practitioner or APP to work with this giant group of different diverse group of physicians and staff who have very good expertise. So thank you for having me on the panel as well.
Thank you so much. And I think in the last minute that we have, I would sincerely like to thank all the participants for their very informative and engaging session last hour. Fairly eye-opening, things you don't think about that get put in perspective very succinctly, very nicely. And I'm glad we had, I think for me, the best part was the last 20, 25 minutes of discussion that we had, which was fairly eye-opening. Again, thank you all for attending. Hope you find this useful, and hopefully we will continue to do what is right for our patients and evolve in the right direction, keeping them front center of the decision making. I think the future is bright in cardiology and patient care. I think, a two-way dialogue helps everybody. It helps float everybody's boats. I strongly believe. Thank you so much for joining.